Hello, everybody, and thanks for joining to talk today about benzodiazepines. My name is Christopher Blazes. I'm a faculty member here at University of Michigan. I'm an addiction psychiatrist as well as an emergency medicine doc, and this is a topic that I face in both worlds, and as I'm sure do most of the people who are listening. And it's a difficult, challenging situation. So I'm grateful that people are giving attention to this. And I'm going to start off with a tidbit from a song, which is relevant. So I'll start with that. So many out there might recognize this little yellow pill that the Rolling Stones were talking about is actually Valium, which is one of the benzodiazepines. And it's an interesting song. And I mean, benzodiazepines have reached into pop culture in deep ways, and we're going to talk about those today. So once again, my name is Christopher Blazes. I'm a faculty here at University of Michigan. I put these two people up here. Normally, I ask people who they are in the audience, and this is Plato and Aristotle. And a lot of people are probably wondering why this is up here. But this is a very controversial issue that we're talking about today. And when I'm faced with controversial issues, oftentimes I'll recognize that there's opposing views, each of which have value. Now, Plato and Aristotle were contemporaries. And they were two of the smartest people of all time and the greatest thinkers, but their opinions were often opposing. And I use this as a reminder to myself that if I become fixed in my opinion, and I'm identifying with Plato, for example, I have to recognize that there's an Aristotle at the other side of the topic, whose opinion is just as valid and well thought out as mine. So I invite you all to kind of enter into that thought process as I do when we're talking about controversial issues. So this next person is Socrates, who was pretty much the teacher of Plato, and I use him as the archetype of someone who has mastered cognitive dissonance. And cognitive dissonance is a psychoanalytic term which just means our capacity to hold paradoxes inside our head, opposing opinions, and allow both to exist without discounting either of them. And when we're talking about controversial issues, I think this is kind of like the holy grail when we're learning about this, is to be open to the other side of these topics. I'm also going to quote Friedrich Nietzsche. So, convictions are more dangerous enemies of truth than lies, because part of what we'll learn today is that we've been misled by facts. And there was another movie, and you can find wisdom in strange places. And I'm just going to quote this. This is Hans Landa from a Quentin Tarantino movie. He said, "I love rumors. Facts can be misleading, where rumors, whether true or false, can be revealing." And that seems a little bit of an odd thing to talk about in a scientific community. But sometimes when we get conservative and fixed in what we think of as facts, that prevents us from seeing the truth and adapting. So this is just a brief overview as to what we're going to talk about today. I have no important disclosures. All right, the last piece of culture I'll talk about, I promise, is Aldous Huxley and the Brave New World. So he, in 1932, wrote a famous book. He's one of my favorite authors. And in this book, it was a chemical dystopia, which I would argue has in some way manifested in our world today. And so there's this idea, a psychoanalytic term called psychic determinism. And what that means is that if we hold something in our unconscious mind for a certain amount of time and repetitively process it, eventually our egos will end up manifesting that in our worlds. So a lot of people, if a lot of people read science fiction, things in science fiction eventually end up becoming reality. And so if you do happen to remember A Brave New World, just think back to it and think of the similarities relative to benzodiazepines. Just a quick overview, I won't spend time, but it was a chemical dystopia, and Henry Ford was worshipped as the prophet. And this is a society where everyone is happy because soma, which is a medication, it cures all pain. And all suffering resolves when we dissolve into the collective. It's oppression through making happy. So, and unfortunately, in this world, and probably in the Brave New World as well as our world, individual effort can be painful. Efforts to create, to evolve, to change can be painful. And in this society, all of these efforts were treated by giving them soma, which kind of creates this comfortable numb situation. So for those of you who've watched The Matrix, we can understand that there's a certain necessity to suffering in our world. It's a call to action. Pain is a call to action. And there's a certain degree of suffering that's necessary for kind of the human condition. All right, so let's go back and let's review some basic terminology, which actually has relevance to understanding benzodiazepines. So initially, for a while, I was confused. I thought that there was a benzodiazepine receptor, but this is kind of like a trick slide. There's no such thing as a benzodiazepine receptor. But benzodiazepines act at the GABA receptors, and so we are going to spend some time talking about this. And why is GABA so important? The bottom line is GABA and glutamate together are involved in the balance of the brain, the homeostasis, and its capacity to have excitatory activity and inhibitory activity. And it's the balance between the two that actually 90% of all neurotransmission in the brain is related to maintaining this balance. And the GABA receptor is the primary inhibitory neurotransmitter in this. So a very large percentage of all neurotransmission is involved in this balance. And GABA and glutamate are present in practically all CNS functions in the brain. And a well-functioning brain needs to maintain this balance. So one other thing, just kind of housekeeping to help people in the audience. One thing that confused me for a while is I would hear NMDA and I would hear glutamate, and they would. The truth is that think about them synonymously. NMDA is the receptor, and glutamate is the primary neurotransmitter that is active at that receptor. But for all intents and purposes, you can think of them as the same. So I like pictures; they help me remember things. So GABA is the primary inhibitory neurotransmitter, and I associate that with Ben Stein, who's kind of like the guy from Ferris Bueller who always used to sit there and say Bueller, Bueller. And he just has a very monotone voice, and just like his persona seems to kind of slow things down in the room. And the opposite to that is Richard Simmons, who his energy is just so activating. And so it's like I associate GABA with Ben Stein and Richard Simmons with the NMDA and the glutamate relationship. It does actually get more complicated than this. There's two completely different types of GABA receptors, and these actually do have some clinical relevance. So we're not going to get into the weeds of this, but I will also present just another picture that can be helpful. So all you really need to know to differentiate the GABA A and the GABA B receptor is that just remember the tortoise and the hare. So the GABA A receptor kind of represents all the usual suspects, the medications and the drugs that we see all the time, benzodiazepines, the Z drugs, the barbiturates, and the alcohol. This is a ligand-gated ion channel, and it mediates a large and rapid increase in neuronal inhibition. So it kind of packs a punch to it. It's quick and it's rapidly acting. And so that's associated with the hare. Now the GABA B, on the other side of things, it's more of a kind of like a slow inhibitory tone over time. And so I envision that as kind of like the Tai Chi side of things, or the tortoise. And what's interesting about the GABA B is that we'll talk about it later, but some of these medications might be more helpful in the treatment of people who are coming off benzodiazepines because of this property of slow maintenance inhibitory tone. So this is the GABA A receptor. There's 5 subunits, and this is just for your reference so that you can see that each of the different drugs are positive allosteric modulators, which just means that when they're attached to the receptor, they allow increased activity at the receptor. This slide helps me remember to let you guys know how diffuse the GABA activity is throughout the brain, and also predominantly it appears to be in limbic structures, which, as many of us know, when we're talking about addictions, the limbic structures have a powerful function within the addictive pathways. So the story that I'm going to tell today about benzodiazepines is a pretty dark story, and I want to preface this by saying that these are important, powerful, useful medications in the right circumstances. So this is kind of like the Aristotle side of things, just as a reminder that hopefully by the end of this talk you'll recognize the darkness that surrounds this whole idea of benzodiazepines. But still remember there are many important uses for these medications in the future, and I continue to use them in certain circumstances. So just a brief overview of the major uses for benzodiazepines in the outpatient setting, and mostly they're used for anxiety and insomnia. So, and these are two very, very prevalent problems in the United States. And so this is just some data that shows that approximately 20% of the population in the United States has a one-year prevalence of anxiety disorders. In insomnia, the numbers are actually as high as 30%. And this is important because the reality is that when people have insomnia or anxiety and they take a benzodiazepine, that immediately makes them feel better. It makes their anxiety feel better. It immediately makes them pass out where they think they're sleeping. We'll learn later that it's actually not regenerative sleep. But it can be quite invalidating to people when they come in and they say, no, doc, you don't understand. This is the only thing that works for me. And in some sense, that's true. And I find that it's important to validate that. But the point is, at what cost? And this is where kind of the expertise comes in. Because sometimes it's hard to connect the hip fracture from the fall related to the Xanax. But that's our responsibility as the physicians sometimes to make these connections and to show patients what some of the costs are. And we're going to review a lot of those today. So when there's lots of suffering out there that's happening as a result of anxiety and insomnia and whatnot, and there's money to be made, this is the story of kind of what happened here kind of in the Western world. So it all started with barbiturates, and I'm going to talk about I'm going to put up this flag that talks about facts. So one thing is that, barbiturates came out, and we talked about how this is the new wonder drug that's safer than opiates for sleep and anxiety. And this is the facts that we were told by the literature and the drug companies. And I'm also going to show some slides from some of the marketing of the drug companies during this time. And some of these are pretty dark. So this is a barbiturate, and it talks about how when she overreacts to any situation, you can just give a barbiturate to cause sedation without the sedative days. And this is where some of the darkness starts. What you'll notice is that there's a trend here. A lot of these marketing, a lot of these advertisements were distinctly directed towards women. And we'll see later that the prevalence, even to this date, for benzodiazepine use is mostly in women. So barbiturates were pharma's first early attempt to convince us that we needed a pill to cope, just like this advertisement here. So this poor woman has to tolerate playing with her child. So a daytime sedative for everyday situational stress. And think back to the Brave New World, right? All these situations that are stressful or problematic, just take your soma, take a pill, it'll make it better. But then we soon learned that these were not safe also. Marilyn Monroe and Judy Garland actually died of overdoses of barbiturates. So then came the benzodiazepine. We were told these are facts now. These are safer drugs than barbiturates. And the first one that was created is 1954, which was chlordiazepoxide, which is Librium, and subsequently multiple more were marketed over time. And they were heavily marketed to treat the stressors of life, like going to college, like raising kids, and marriage, and getting old, and all these responsibilities. So once again, we were kind of convinced that we needed a pill to cope with normal everyday activity. This happened only 20 years after A Brave New World. And their marketing was very successful. And in a way, they created their own demand by pathologizing normal conditions. And this is another trend that will follow through this. And this was actually a grand success in marketing. By 1974, 60 million Americans were prescribed Valium. That's 28% of the population at that time. That's pretty remarkable. So, and the marketing actually destigmatized anxiety. And as we talked about before, much of this was directed towards women. So here's another slide. This poor woman, you can help her, set her free from being trapped behind this prison of mops and make her, you can't set her free, but you can make her less anxious by giving her Syrax, which of course is a benzodiazepine. Then came Xanax, our favorite palindrome, and they needed to find their own little niche in the market. And they capitalized on the fact that this was a very fast-acting medication. So if you were having a panic attack, Valium wasn't fast-acting enough, so you needed to have something like Xanax. And once again, they even popularized the idea of a panic attack. And then they found their niche there. So this is another one that, and this to this day, Xanax is prescribed a lot by a lot of the psychoanalysts. And they talk about here how it complements an effective therapeutic alliance. And this is one of my favorites. But by now you get the idea. So in a world where certainties are few, no wonder Ativan is prescribed by so many caring clinicians, right? No wonder. But the other way to look at this is no wonder. From my experience, when I see people who are taking benzodiazepines, they have a lack of capacity to wonder at things, which is an important part of the human experience. So how effective was all this marketing? Well, according to our own Donovan Moust here at University of Michigan, when he reviewed the NSDUH data, which is a great survey of 70,000 people, in-person survey every year, he determined that about 12.6% of the population in the United States in 2018 was prescribed benzodiazepines. I actually suspect it's higher than that. And there's still a 2-to-1 female to male ratio. And also pay attention to the right side of the screen. In the high school population, some people say 5% of high school students are prescribed benzodiazepines regularly, and they say 8% use them illicitly. And I actually, from my experience, suspect that's even higher. And then for those of us who are interested in addiction like me, that bottom statistic is quite scary. The benzodiazepine prescriptions are disproportionately high in the populations on MAT. So Suboxone and methadone patients, up to 25% of these patients are co-prescribed benzodiazepines. And as we all know, this is a dangerous combination. So chronic daily use also increases with age. So whereas 14.7% of young adults use benzodiazepines on a daily basis, as we get older, the number gets higher. 31.4% of elderly patients who are taking benzodiazepines take them on a daily basis, according to the study I have referenced. So this is a nice slide just to kind of give you the idea that there is a direct linear relationship between age and benzodiazepine prescriptions. So as we get older, the likelihood of us being on a benzodiazepine increases linearly. And also, this shows you how women are prescribed much more than men as well. And it only gets worse. This was a nice study that came out in 2018, by Anna Lemke from Stanford and New England Journal. And she just noticed the fact and brought to our attention that despite all of these increased risks of overdose that we are learning about, that the benzodiazepine co-prescription with opiates continues to increase, and it was actually doubled between 2001 and 2013. So it keeps getting worse. So, but we have to be careful not just to blame the drug companies, because we as a system are also complicit in this. Because let's just review what DEA scheduling is. And Schedule 1 means that it's like the most addictive drugs that have no clinical uses, and Schedule 5, which is the least addictive potential. So Schedule 1 to Schedule 5. And so what is benzodiazepines? Well, the truth is they're listed as a Schedule 4, and the definition of a Schedule 4 is low potential for abuse and a low risk for dependence. And these are facts that we were told by the DEA, our governmental body. And I think most prescribers in the audience would clearly recognize that they definitely have a high potential for abuse and a high risk of dependence. but yet they're still listed as a Schedule 4 drug by the DEA. So this, to me, was a game-changing article when I read it. Because from clinical experience, it was obvious that benzodiazepines are addictive. But this study clearly shows that benzodiazepines cause a dopamine release in the nucleus accumbens. And that is the final common pathways in all drugs of addiction. A drug of addiction is defined, in the scientific community as causing a dopamine release in the nucleus accumbens. This was a good study published in Nature, which shows that benzodiazepines cause dopamine release in the nucleus accumbens, which is the final common pathway for all drugs of abuse. So how does this all add up, right? There's less stigma from the marketing. It's cool to be on Xanax. We learned that there's direct dopamine release into the reward pathway. There's inappropriate scheduling by the DEA. And this last thing, pay for performance, which is something that's worth talking about as well, that also contributed to the problem that we're in. So Press-Ganey, most people out there probably are familiar with this, and this is when patients are given a survey at the end of an ER visit or a visit in an outpatient or inpatient setting, and they evaluate how happy they were with the service that they got. And there's some problems with this because, for example, when someone comes to my office and they want a prescription for a benzodiazepine, it might take me a long time to convince them that this is not the right thing for them, and they're going to end up leaving unhappy. Whereas and that's going to take much longer. It would probably be like a 45-minute conversation versus if I spend 5 minutes, write a prescription, say, here's your benzodiazepine, and don't go through the process of explaining why it's a problem. They're going to leave there and they're going to be much happier. And the trend is in the modern world is that in a lot of situations, people's pay is directly proportional in some sense. There's incentives to your patient satisfaction. And a lot of these patients are clearly not going to be satisfied if they don't get their prescription for benzodiazepines. So the end result of all this is that benzodiazepines are the most prescribed psychiatric medications in America. Xanax is number 1 and Ambien is number 2. So what else? The bottom line is a lot of people get addicted to these drugs. 50% of chronic benzodiazepine users meet criteria for benzodiazepine dependence. And this is the old terminology from the DSM-4, where dependence was the term for addiction. So, and it only takes a month to get addicted. So this study showed that benzodiazepine addiction happens in 50% of patients taking for greater than 1 month. That's a pretty scary statistic in my mind. I put this slide up as a reminder that, most of us know as clinicians that not all benzodiazepines are equal. And I spent some time in San Francisco, and there's an area called the Tenderloin, which is kind of like this free drug market where the police allow people to sell all kind of prescription and illicit drugs and kind of, don't arrest them for it. And one thing that we learned is oftentimes, the addictive value of a drug can, in some sense be tested by whether or not it's available in these illicit markets, and which ones are more expensive. And as it turns out, in the Tenderloin in San Francisco, Xanax is more expensive and is sold more in the Tenderloin than Klonopin and then more than Ativan. But interestingly, other drugs, benzodiazepines that you can't buy in the Tenderloin are oxazepam, Librium, and chlorazepate. So I had a patient when I was in San Francisco. I gave him a prescription for Librium, and he brought it back 2 days later. He gave it back to me. He's like, you know what? I can't even sell this over in the Tenderloin. You take it. And this is helpful, clinically relevant information because if I'm actually going to end up prescribing something to somebody as an outpatient, I'll be much more likely to give him one of these that have less abuse potential. So altogether, everybody say which benzodiazepine is the most evil, and I think everyone would agree that Xanax is. And this is a good article to reference. We don't have time to go into the specifics today, but it was a very good, thorough review that came out in 2018. It talked about specifically Xanax and why it is fundamentally different and why it seems to be the worst benzodiazepine. They documented such things like that the withdrawals truly are worse than other benzodiazepines. they gave data that shows that it's used more, it's misused more, and it's more toxic in overdose. And one interesting piece is that you're twice as likely to end up in the ICU after an overdose of Xanax versus other benzodiazepines. And this slide is just kind of a reminder that there's still some interesting uses of benzodiazepines. There was a Cochrane review that came out as recently as 2012, which made an argument that Xanax is a great drug to treat depression, and the reason was that it clearly improved patients' HAM-D scales. And the reality is that opiates would probably improve patients' HAM-D scales as well. So this is one of those controversial topics. So let's go back to our Plato and Aristotle. But in my mind, using benzodiazepines for depression is not something that's in my clinical practice. So I just invite you to kind of reconsider some of these, old dogmatic ideas. So this is just some more data supporting that not all benzodiazepines are equal. And this just listed the most common benzodiazepine. And if you are prescribed a benzodiazepine, the likelihood that you will end up with a complication in the emergency department. And if you were given Xanax, you were more likely to end up in the ER with a complication than Klonopin, which is more likely to end up in the ER than Ativan, than Valium. And interestingly, I think that that's roughly proportional what I would kind of describe as the abuse potential. So that's an interesting study as well. And in 2001, it's an old study, but it's a good one, that showed that alprazolam created a greater dopamine release in the striatum, which is another word for the nucleus accumbens, than lorazepam. So, and I'll leave this up for your reference, but the most important thing to point out here is that it's been shown that people can become physiologically dependent to Xanax after only a week's use. Now, that's a pretty scary statistic because oftentimes we'll easily, prescribe for a week or two and not worry about someone becoming physiologically dependent, but it actually can happen with Xanax in 1 week. So even more scary than that is that if somebody's been on Xanax for a long period of time, they have idiosyncratic withdrawals. And I've noticed this in my own clinical experience, and it's nice to know that there's data to back it up, that it just doesn't seem to respond to the typical measures for the treatment of withdrawal, as well as the other benzodiazepines. So lorazepam, chlordiazepoxide, and diazepam have been shown to be ineffective in treating the withdrawal symptoms from Xanax. So there's limited data that clonazepam might work, but from my experience, I end up using anti-epileptics or phenobarbital. And we'll talk more about those specifics later. But classic treatments don't work as well for Xanax withdrawal. This is an important slide just because, it's hard to remember all of this P450 stuff, or at least it is for me, the way that my brain works. But grapefruit juice, if people take grapefruit juice, that will actually slow the breakdown of benzodiazepines, and there'll be increased efficacy of that. So, I have ambivalence about whether or not to tell patients this, because if people are prone to addictions and they like the effect of a medication, then they might just kind of go out and use grapefruit juice to increase the efficacy of that. But for us as physicians and clinicians, I think it's an important thing to know, because this is a very real activity. Actually, when I was in San Francisco, one of the things that we did was, if people were slow metabolizers of methadone, rather than splitting their daily doses, sometimes we actually gave them grapefruit juice, and there was efficacy to that. So just a few odds and ends before we get into the withdrawal. I wanted to spend a few moments talking about gabapentin, because this has really been taking up a lot of space and attention in the recent past few months. So the mechanism, we actually really don't know how it works. There's multiple theories on it, but the end result is that it results in increased GABA activity. But we know it does not act on the GABA receptor itself. Indirectly, it results in increased GABA activity. There is some abuse potential, and you can buy it in the Tenderloin. But what's the reality of it? So I did a deep dive into the research. And from what I found is that there's no evidence that it causes a dopamine release in the nucleus accumbens. And from my clinical experience and through kind of discussion through listservs and blogs from a lot of experts, I think the abuse potential is low, with one exception, and that is if people are taking opiates, it distinctly enhances the euphoria of opiates, and that includes Suboxone as well. So, and I encourage you to ask your patients this. Like once people are kind of open with you and in early recovery and discussion about this, ask them what it was like when they took gabapentin in addition to their opiates. And there actually is literature to support that it does enhance the euphoria of opiates. But I also left this in for your reference because it's kind of a good review talking about how addictive gabapentin is. The jury is still out. I continue to prescribe it quite liberally in patients who are not on Suboxone and not on opiates because I think it's a great drug to treat post-acute withdrawal, which we'll talk about later. And this is just a couple other studies for those of you who are geeky like me and want to know more about the gabapentin. But this combination with opioids is real, and from this one study, in patients with chronic pain, the use of gabapentin and an opioid together increased the risk of opioid-related deaths by 60% versus the patients just taking an opioid alone. So there's certainly some relevance to this combination, and I never prescribe it in combination with opiates. All right, so let's switch gears for a second. So I put this slide up because I just think it's important to know. I think the word addiction has gotten a bad name, but I would make an argument that we need to change the stigma and not change the word. Shakespeare actually invented the word addiction, and I think that in a lot of senses it's much more descriptive than use disorder for a certain population. All right, so let's switch gears to talk about the Z drugs. So the Z drugs came out again, and they were listed as the safer alternative to benzodiazepines. And most people know that these are the sleeping pills: Ambien, which is Zolpidem, Azopiclone, and Zaloplan. And these are also positive allosteric modulators at the GABA A receptor. But just as a reminder, in the past, we were told many things that were facts. We were told that Ambien and the Z drugs were safer alternatives than benzodiazepines. But the reality is they probably aren't. So Z drugs are used to treat sleep, but the reality is they actually do not induce a natural type of recovery sleep. And it's been shown that they decrease activity in inhibitory parts of the brain, which can lead to activation in people who do things like sleepwalking and whatnot. So the reality is it knocks people out, but they don't get the regenerative sleep. And it's been shown that benzodiazepines as well as Z drugs actually decrease the delta wave activity during sleep, which is the regenerative side of sleep. It's also been shown to increase the beta activity while people are sleeping or sedated. And the beta activity is what hopefully all of us are using now, which is the kind of like the thinking active mind. So you have increasing beta activity while you're asleep as a result of benzodiazepines and Z drugs. So how does this all end up? The reality is that in a lot of cases, many experts, consider Z drugs to be the same as benzodiazepines. And one of my mentors at UCSF, Steve Bakke, he says, I consider them to be the same, and they're actually now even studied together. And the reality is, in rehabs across the country, there are people who are coming in who are solely addicted to Ambien. I haven't seen the other Z drugs, but these are powerful medications, just like benzodiazepines. So this will just be in here for your reference for later if you're curious about to read further about how the abuse potential of Z drugs. So Ambien's also been shown to have a direct correlation with suicide. This was a large study in Taiwan which showed that if, as an independent risk factor, if you were on Zolpidem, you had a twofold greater increase of suicide after adjustments for all these other things here. So let's summarize the bad news, all right? So I'm going to go through a list of problematic things that happen as a result of being on benzodiazepines and Z drugs. And I think these are important to know about because when I tell patients about this, they're shocked. And when I tell physicians about this, they're also shocked. So there's a list of problems that happen. A lot of these you guys know, but we'll just review them. Everyone knows that there's cognitive impairment when people take benzodiazepines. And I left some references here if you want to look further into that. The impairment is prominent, and this is a picture of Tiger Woods when he was, arrested on the side of the road, and he had benzodiazepines and opiates in his system. Clearly known that even therapeutic doses can cause, impaired mental alertness and cognition, especially in naive people. But there are cognitive impairments in people who've been taking them chronically as well. There's overwhelming evidence, both experimental and epidemiological, that benzodiazepines and Z-drugs are implicated in fatal and non-fatal MBAs. And this is from a meta-analysis, recent meta-analysis in 2017. So it's kind of hard to argue these correlations because there's so much literature that's coming back positive for that. And the same thing is true for Z-drugs causing impairment. They significantly impair driving performance, cognitive, memory, and psychomotor performance on the morning following bedtime administration, according to this one study. I want to talk about falls for a moment, and this sometimes, can seem somewhat insignificant, but falls are a really big deal, especially in the elderly population. Sometimes a fall from standing can result in subdural hematomas or hip fractures, which can end up with, debilitating situation that can result in PEs and whatnot. It can be the beginning of a downward spiral and the beginning of an end. So just because this is old evidence and there's decades of evidence doesn't mean that it's not meaningful. But it's pretty convincing evidence that there's a direct correlation in the elderly population between benzodiazepine use and falls. And I just left a couple studies in for your reference. This was very revealing to me when I did a dive into the literature to talk about dementia, and to realize that there is some controversy here. There are some experts that will argue that the dementia is only related to, cognitive impairments that happen as a result of people while they're taking the drugs. And they would argue that when patients come off the drugs that they no longer have dementia. But I'll tell you that the jury is still out. And the predominance of the literature shows, and this one study's meta-analysis showed that 9 of 10 studies showed increased risk of dementia with benzodiazepine and Z-drug use. Of clinical relevance, it's more associated with a higher dose, which is obvious, as well as long-term use, which is obvious, as well as longer-acting benzodiazepines. And a key point to remember is that for people who have been taking benzodiazepines for longer than 3 years, there's some evidence that this is irreversible dementia. So benzos and Z-drugs have also been shown to have a direct correlation with increased mortality. And this is an impressive study of 35,000 patients in the British Medical Journal in 2015. And they actually followed 35,000 patients for 7.6 years. And the age-adjusted hazard ratio for all-cause mortality was 3.46 after adjusting for co-founders. So in reality, just if you're on a benzodiazepines, you were 3.5 times more likely to die as a result of being on those drugs. That's pretty scary numbers. And that's, this is a study that I often will bring up when I'm talking with patients. And my inclination is that they would be better coming off their benzodiazepines. So despite knowing all this, the prescriptions are increasing in size, despite all the evidence that we have of all the problems that are happening. So between 1996 and 2013, our benzodiazepine prescriptions increased, according to this one study, from 4.1 to 5.6%. But what's more relevant is that the quantities of each prescription actually tripled during that time, despite the fact that all-cause mortality increased. So we're prescribing it more in much higher doses, despite knowing all of these increased risks. So we talked about how Z-drugs have a correlation with suicide, but actually, if you go into the literature, benzodiazepines have a significant correlation with increased risk of suicide. There was a pretty good meta-analysis in 2017, which was a review of 17 relevant studies, and its conclusion is that benzodiazepines distinctly increase the risk of suicide, and it was more associated with Klonopin. The thought is that this was mediated through behavioral disinhibition. So, and the majority of these 17 studies, showed that the benzodiazepine use was associated with increased risk of suicide. And interestingly, this is just have these for your reference if you're curious to delve into it further. But one of these studies was even stopped early because there were such severe consequences of the behavioral inhibition as a result of the benzodiazepines. And some of these examples were overdosing, jumping in front of a car, and throwing a chair at a child as a result of being on a benzodiazepine. So it's also been shown that there's a direct correlation between benzodiazepine use and pneumonia. So there was a recent meta-analysis that came out that showed that of 10 studies that there was a direct correlation between benzodiazepine use and developing pneumonia. So many of us know that it's also problematic in terms of drug interactions. So certain medications that are thought to be safe and known to be safe, like Suboxone, if you combine them with benzodiazepines, they become dangerous. And so the ceiling effect that we all appreciate about buprenorphine disappears when it's combined with a benzodiazepine. And I left these references in for those of you who want to look further into this. So I want to spend a moment talking about this benzodiazepine and Suboxone issue because it's actually kind of confusing and it's complicated. So hopefully we'll clear up a little bit of this. In 2016, the FDA placed a black box warning, which is its highest level of concern, on the package insert, warning people that buprenorphine, when you're prescribing buprenorphine, it should not be prescribed to people who are taking benzodiazepines. So it's a black box warning. You shouldn't do it. But then in 2017, there was a drug safety communication which came out, through email, which sometimes, we're hit with a barrage of so much information, it's hard to know what's important. And this is one of those things that very easily could have slipped through the cracks. But the safety communication in 2017 basically said that buprenorphine should not be withheld from patients who are already taking benzodiazepines as prescribed, because the risks of overdose from opiates outweigh the risk of this concomitant benzodiazepine and buprenorphine use. So this kind of puts us in a hard situation as prescribers, right? But the reality is, because the black box warning is still there. So just so people know, if people are prescribed buprenorphine, it's not okay to start a new prescription of benzodiazepines. But if they're already on it, according to the FDA, you have freedom to prescribe the buprenorphine. So when are these meds still indicated? And it's important to remember, like we talked about before, I'm telling a dark story, but there certainly are times that I continue to use benzodiazepines. And I'm still a practicing emergency medicine physician, and I use them all the time in my emergency medicine practice for procedural sedation, for severe acute agitation. I use it, in inpatient psychiatric circles for mania or agitated psychosis. And we don't have time to go through the exhaustive list, but in reality, there still are many appropriate uses for benzodiazepines. From my perspective, most of these uses are for short-term use, but there still are some long-term appropriate uses of benzodiazepines. So what do we do now? If we've decided that benzodiazepines, it's important that we get patients off these benzodiazepines, so what do we do? The problem is discontinuation is almost universally will result in a withdrawal syndrome, and this withdrawal syndrome is really painful for patients. And I put up a picture of an ER waiting room because I keep seeing it more and more and more, that people are being forcefully deprescribed these benzodiazepines, and they end up kind of like flooding the emergency departments in severe distress. So hopefully we can mitigate some of this from happening. So what's the best way to help people get off these drugs? So I'm going to start off with a Cochrane review that came out in 2018. For those of you, just as a reminder, a Cochrane review was thought of as kind of like the best evidence-based meta-analysis review of the literature. And so this came out, and the author's conclusions were, when talking about helpful ways to get people off benzodiazepines. Given the low or very low quality of evidence for the reported outcomes and the small number of trials identified with a limited number of participants for each comparison, it's not possible to draw firm conclusions regarding pharmacological interventions to facilitate benzodiazepine discontinued in chronic benzodiazepine. But this is, in reality, what our options are. So, and I listed them kind of in the relative order of the popularity of use. So these are our four options. Number one, convert to a long-acting benzodiazepine. Number 2, and then taper that over a period of weeks to months. Number 2 is to use a prolonged taper on the same benzodiazepine. Some people do 50% initially and then 10% week for a week thereafter. Number 3 is to convert to an anti-epileptic or phenobarbital and then to taper that medication. And number 4, which is still sometimes used as a water taper, is to dissolve the benzodiazepines into solution and to decrease the dose by such a low amount every week that people won't even notice the decrease in the dose. So what is the standard of care at this time for deprescribing benzodiazepines? So there was a New England Journal of Medicine article that came out in 2017 by Soika, which was quoting a Cochrane review, which I'll talk about in the next slide, that says the overall consensus is that benzodiazepines should be discontinued gradually over a period of several weeks to avoid seizures and withdrawal symptoms. So for the most part, most people will use this as the standard of care. But we have to be careful with, because sometimes if you don't read the specifics of each article, we can miss out on some things. And if you dive into the depths here, the 2 main Cochrane reviews that Soika quoted to come up with his recommendation are these 2. The first was an Amato Cochrane review in 2010, which talked about benzodiazepine safety in the treatment of alcohol withdrawal, but it had nothing to do with using benzodiazepines for the treatment of benzodiazepine withdrawal. So it was a false correlation to make. And so I would argue it's inappropriate to use that as a basis for his previous statement. And then the other Cochrane review was a darker Cochrane review in 2015, which was a meta-analysis of CBT plus a taper versus a taper alone for benzodiazepine withdrawal. So the bottom line is there's actually no studies which evaluate a taper versus a rapid discontinuation or transition to an anti-epileptic, which I'll cut to the chase, which is what I use in my practice and is my ideal choice. Okay, so we have a question. That's a tough question. I think that what I usually do is I increase the frequency with which I see them. So if I see them on a monthly basis, I'll end up seeing them on a weekly basis. And then I encourage them to, I try to establish, a firm boundary to say that we're going to work with you on this, but that long term, this is not going to work. But you're going to get differing opinions on this. So I'll increase the frequency with which I see them and engage them more frequently. But it's a complicated issue. So it's a good question. So just to get back, this is a picture of Rick Reese, who literally wrote the book on addiction medicine. He and I have spoken about this topic, and he and I are like-minded with this. He doesn't believe benzodiazepine tapers work at all. I'm a little bit, there are some situations where I believe they do work, but he universally transitions people to an anti-epileptic, either Depakote or carbamazepine, or in more people who are on much lower doses who use gabapentin, and then he'll taper that medication over time. And then he'll continue, so he'll do a rapid taper of a benzodiazepine over a period of 3 days. Then he'll continue the anti-epileptic for a period of a month or so afterwards. But one of the things about this method, though, is just to warn people, this is something that we pretty much only do as an inpatient, unless somebody is really healthy. If they have any comorbidities, I think it would be inappropriate to do this as an outpatient. And so I always try to facilitate an inpatient rapid transition if I'm using this method. And this is a reminder not to forget supportive measures, because alpha-2 agonists and gabapentin are powerful medications to help people through the withdrawal phases of benzodiazepines. So even if you're doing a taper of benzodiazepines, you can give some clonidine or even some guanfacine, which is 10x, and that can help people tolerate the taper even better if you decide to do the taper. So for all those researchers out there who are interested in doing some meaningful research, I think it would be really great to find a study that compares the standard of care taper, which is to switch to a long-acting benzo and taper it over a period of weeks to months, versus the Rick Reese style rapid cross titration to an anti-epileptic medication and a rapid taper over 3 days. I think it would be great to have a better body of evidence to look into that to compare the two. So another word about hospitalization. So if we decide to do a rapid taper and cross titration to an anti-epileptic, it's best to do that as an inpatient. And according to the DoD guidelines, back in 2013, actually for anybody who's even on super therapeutic doses of benzodiazepines, they recommend that taper be done as an inpatient. And this is the standard of care in certain areas of the country. So I put this up as a nice reference for those of you who are interested in this. This is a study that came out of Johns Hopkins, which showed that inpatient barbiturate can be used as a rapid and safe detoxification from benzodiazepines. And they showed that that this was done safely in 300 patients in a rapid detox of only 3 days using phenobarbital. And so this is just a reference for you if you choose to do this. So how do you choose? I mean, this is a complex situation. Whether or not I'm going to use a taper versus I'm going to admit somebody to the hospital and do a rapid transition, it's challenging. And I'll just tell you a few pearls that I've learned over time. If somebody has an addiction to benzodiazepines, I can say that in my career, I have never seen somebody who has an addiction successfully do an outpatient taper. Because it's different if you're physiologically dependent or even if you're misusing than an addiction. So that's one. And number two, I think the patient's motivation is probably the most critical factor. If somebody comes to me and they really, really want to get off the benzodiazepines, the likelihood that they will tolerate an outpatient taper is much higher. But also, I think it's important that they need to recognize that this is going to be a painful process when they're going through the withdrawal. And that's why I put a picture of Coach up there, because it's important that they have significant support in their lives. And ideally, even somebody who can kind of help dispense the medications and to remind them that the discomfort that they're feeling and the irritability and the anxiety and the frustration is related to the slow withdrawal, the subtle withdrawal that's happening from the decreasing doses over time. So why all this debate? I mean, the reality is withdrawal is really bad news, right? Benzodiazepine withdrawal is actually dangerous, and there's really no controversy here. In comparing it to alcohol withdrawal, it's more associated with seizures. You're more likely to get psychosis and more likely to go into delirium. It's dangerous and it's miserable for patients. So in general, it's similar to alcohol withdrawal, but it's variable in length, and it's much more likely to cause seizures. Almost universally, people will end up with rebound symptoms of the reasons for which they started the medications. So they'll get increased anxiety and insomnia. So first and most reliably, that's what they end up with, is the rebound anxiety and insomnia, and it comes back with a vengeance. And this will often start between 48 and 72 hours after stopping the benzodiazepine. But I put a pearl down there right at the bottom. You have to be careful. If patients are on longer-acting benzodiazepines like Valium or whatnot, they may not have any withdrawal symptoms at all for 5 to 10 days after they, discontinue the medication. And sometimes once you're 10 days out, you might not put together that this is related to a medication that they stopped 10 days ago. So that's just an important point to remember. This is just a nice review slide talking about some of the withdrawal symptoms of benzodiazepines. I put the yellow star next to the hypersensitivity to light, noise, smell, and touch, because this is something that from my clinical experience is more profound with benzodiazepines than with alcohol. They really do notice this hypersensitivity. So this is a nice picture, a nice cartoon showing that Klonopin withdrawal, if you look, everybody knows it can last for a couple of weeks or even longer, but then you'll see that it goes out to months and years. And that's something that I want to spend some time talking about, because there is actually a reality to that. And we'll get to that later, talking about the post-acute withdrawal. And so what's the mechanism of this? And this brings us back to the Ben Stein and the Richard Simmons, to the GABA and the glutamate relationship. Remember that 90% of all neurotransmission in the brain is related to maintaining this balance between GABA and glutamate. And And so the benzo withdrawal has to do with an elevated hyperadrenergic state over time, because the body had compensated to excessive sedative and inhibition over time by increasing its adrenergic state, its activity state. So I want to spend a moment talking about the kindling effect, because this is very powerful. Now, kindling effect, what that means is that it's often thought of in terms of alcohol withdrawal. So if somebody's been an alcoholic for 50 years and they go into withdrawal once, the likelihood of them having a complicated withdrawal or seizures or DTs is actually lower than somebody who's been drinking for 10 years but has gone into withdrawal 10 times. Each subsequent time that you go into withdrawal, it sensitizes the body so that the withdrawal is worse. And so we know this in alcohol, and we're starting to learn that this is even more prominent in benzodiazepines. And think about it for a moment. Oftentimes, people who are given prescriptions for Xanax, if they start misusing them, they get a prescription every month, they use it up in 14 days, they may end up going into withdrawal every month. And somebody who goes into withdrawal every month will have a sensitized withdrawal, which gets worse and worse and worse, and they can end up psychotic as an inpatient, or doing disinhibited behaviors like suicide as a result of these multiple withdrawals. So Professor Ashton is a British woman who spent her entire career studying benzodiazepines and how to help people coming off these medications and understanding the vicissitudes of this. This is a nice read if you really want to get into the weeds of this. Just be aware that this was mostly geared towards people who were not addicted to the medications, but were simply physiologically dependent. But nonetheless, there's really good information. So now just to talk about the post-acute withdrawal. So if we've successfully tapered somebody from the benzodiazepine, then what do? Well, then we have to deal with this pause issue. So pause is the post-acute withdrawal syndrome. And this is a set of impairments that can persist for weeks, months, or years after abstaining from a substance abuse. It's called multiple different things. It's called post-withdrawal syndrome. It's called prolonged withdrawal syndrome. It's called protracted withdrawal syndrome. And the symptoms can mimic primary mood disorders, anxiety disorders, or personality disorders. So be aware that this post-acute withdrawal is actually not a DSM-5 diagnosis. It probably should be, so hopefully in the DSM-6 it will be more recognized. And also there's a small amount of literature on this topic, and most of the literature is quite old, from like the 1990s, and it's more associated with the protracted withdrawal syndrome. So we don't have a large database from which to kind of like resource. But it's estimated that 90% of people who are recovering from drugs of abuse experience some sort of post-acute withdrawal. It's also important to know that this will wax and wane in severity, and it may disappear altogether, only to kind of reappear at a later time. The symptoms are very non-specific, and there's many different symptoms of this. I highlighted a few. So people talk about benzo brain. So sometimes it takes like many months, up to 1 or 2 years, for people to recover their cognitive capacities. If subtle problems with like learning and memory and problem solving, so we call it benzo brain. Also, universally, people will have poor frustration tolerance and be more irritable, and have significant disruptions in sleep patterns. And like we talked about before, resurgence of anxiety and insomnia, which were often the reasons they were started on medication. But also note, I had a patient yesterday that talked about how, just things seem to hurt her a little bit more. So hypersensitivity to pain, anxiety, sound also can be a subtle sign that can kind of help us diagnose this post-acute withdrawal syndrome. So these symptoms tend to increase in severity when triggered by stressful situations. But also recognize they might flare up for no apparent reason at all. But because of this intermittent nature of them, they can often lead to misdiagnosis. So people who are being treated for addictions and withdrawal syndromes, end up, stacking up multiple different diagnoses. And it's worth a closer look to recognize that maybe it's not a new personality disorder. Maybe this is just kind of like the post-acute withdrawal that's rearing its head. So I'll leave this in here for reference for people who want to read more. Again, there's not much out here, but so these are some articles talking about the post-acute withdrawal syndrome. One of them that I liked was from Dr. Ashton in 1984, and she basically said complete recovery may take a year or more. And there was another article that came out in 2009 that described coming off of tranquilizers, referring to benzodiazepines, as a Sisyphusian toil. And this is a picture of Sisyphus. So it's kind of like the person who rolled that rock to the top of the hill and it would fall back down. You have to do it over and over and over and over again. And that's kind of a helpful kind of metaphor, for what people are going through. So what do we do about the treatment of this pause? Well, again, there's not a great body of literature, but in general, I think it's best if we think back to the GABA A and the GABA B. It's better to deal with a slow and steady approach to this. So don't forget about adjunctive, in addition to medicines, don't think about the adjunctive stuff, psychotherapy, behavioral therapy, group therapy, even 12-step programming. Acupuncture and other alternative medicines have been shown to be helpful for the post-acute withdrawal. But if we're talking about pharmacological interventions, again, there's not much data out there, but the data that we have shows that anti-epileptics are probably the best way to go with this. So topiramate, trileptal, gabapentin, I actually use a lot of oxcarbamazepine. But in the future, I have a feeling there should be more studies on this, but I think that there's a place for baclofen, which is a GABA B agonist, right? As well as other meds like atomoxetine or alpha-2 agonists. And another plug for the alpha-2 agonist, because for both opiate and benzodiazepine post-acute withdrawal, you have an elevated hyperadrenergic state. And I've had remarkable efficacy from using alpha-2 agonists in treating the post-acute withdrawal. So this is just for your reference, showing that anticonvulsants are, the best drugs for this. So how long do we treat for? Well, the reality is there's no data to help us out. How long do we treat post-acute withdrawal? I usually treat between 6 and 12 months, and depending upon the length of time that the person was on the medication. And why is it so important to treat this? So it's important to treat this because if people are 6 months into their recovery of abstinence from benzodiazepines and they're still having irritability and insomnia and cognitive impairment, remind them that this too shall pass. And that's a powerful piece of information to pass them along. Because if they're in the middle of this and they're like, if this is the way that I'm always going to feel forever, screw this, I'm going to go back and take the benzodiazepines. It's a helpful reminder to help people know that this too shall pass. And just a few things about the future. I think flumazenil is one of those drugs as an ER doc we hate, because if flumazenil is the antidote to benzodiazepine overdose, and it's an antagonist and it blocks the receptor. So if somebody is physiologically dependent upon benzos and you give them flumazenil, you'll cause refractory seizures. But if they're outside of the window of physiologic dependence, there's some evidence that if you attach an antagonist, it will force the body to create a new homeostasis. And there's early evidence that it will decrease the length of the post-acute withdrawal. So we'll skip ahead from some of these slides, out of interest of time. But also, I just wanted to bring up, many of us have heard about opioid-induced hyperalgesia, which means that people who have been chronically on opiates have an increased sensitivity to pain. There's a similar phenomenon that happens with benzodiazepines. If you've been chronically on benzos, anxiety-provoking stimuli tend to create increased stress and anxiety. And this is helpful to remind patients that their level of baseline anxiety might actually be lower after they get off these medications. So in the future, it's important just to recognize that, when they are successfully tapered from a benzodiazepine, this was a good study that came out in 2006 that showed that 88% of these people who successfully completed a taper recommenced use within 15 months. I think this is related to pause. So I think we need to really start to pharmacologically treat this pause to help these people out. I put in a plug for this article for your reference. This is Dr. Maldonado from Stanford. He is making a strong push to use anti-epileptics and alpha-2 agonists to treat alcohol withdrawal. Through conversations with him, he also uses this for benzodiazepine withdrawal. It's not yet ready for everyday use, but be mindful of this article. In my opinion, this is a game changer. And 10 years from now, I don't believe that benzos will be used at all for alcohol withdrawal. And we're going to move towards the anti-epileptics and the alpha-2 agonists. And this is a very, very well thought out, thorough, well-referenced article, which can talk about the physiology and the pathophysiology of why this would be helpful. So just a reminder, once again, oftentimes we'll see like the little old lady who's been on 0.5 milligrams of Ativan BID for 40 years. And it might be possible that the best thing to do would be to allow her to continue to be on this medication, because the complications of trying to come off it might be more severe than all of the problems of being on it. And so what I do in this situation is I have a true extended documented informed consent with the patient and their family, talking about all the problems with the benzodiazepines and the dementia and the increased risk of death and pneumonia and whatnot, but also tell them of the complications of going through the withdrawal process and recognize that it may be best just to keep some of these people on the benzodiazepine. So I'm going to finish there, but I just also wanted to acknowledge the fact that this is a very complicated situation that we're left with. You know, we are tasked with getting people off of these medications, but yet the literature has not caught up in a good way with appropriate data and protocols to guide us through this process. So what are we left with? And I'm just going to put out a plug for, once again, expert opinion. And you know, what I will often do in situations where there's gaps in the literature, there's listservs where I connect with experts across the country who are doing this, and I find out how they're dealing with some of these difficult situations. Because unfortunately, the literature has many of the answers, but as we've learned from this, it doesn't have all the answers. So we have to trust and test and taste, and also just recognize that this is a hard situation that all you guys are dealing with. And I wish that there was an easy answer to give you, but hopefully we've left you with some, some better information to have more informed discussions with your patients. So thank you all. I'm going to end there, and I'm going to open it up for some questions.
Benzos for REM sleep disorders?
I think this is one of those areas where you might get differing opinions. There's a lot of sleep specialists that do continue to use benzodiazepines, but you know, this is the Plato and Aristotle. You're going to get differing opinions. In my opinion, you know, I've not found them to be effective, but again, this is not my area of expertise. I think that they do cause disruptive sleep patterns. And they disrupt regenerative sleep. But this is a point of contention, and you will get differing opinions from different people on this. So the question was, what would I offer for sleep? Well, my favorite medication for treating sleep, especially in people who have addictions or have been on benzodiazepines, I've had best success with doxepin at a low dose. So, you know, 10 milligrams is the lowest dose that it's prescribed, but it came out as an on-label medication at even lower doses at 3 milligrams. So I've had great success from doxepin. I do also use trazodone, but I found that that's more associated with some daytime sleepiness, but I've had success with that as well. So those are kind of my first go-tos, are the doxepin and the trazodone. But what I've also found is that I use oxcarbamazepine for about 6 months into the post-acute withdrawal, and it doesn't classically help with sleep, but people sleep better being on it. So the combination of the oxcarbamazepine with the doxepin has been successful for me. I The question was, do I have an opinion on cyclobenzaprine for pain and sleep at bedtime? And that's not, I actually don't have an opinion on that. But when you were talking about chronic pain, one of the things that I was just reviewing yesterday was I'll put in a plug for very low dose naltrexone. I've been using that a lot for chronic pain and have had significant success with that. Well, I've had recent good success with very low dose naltrexone. So if you'd like, you can reach out separately and I can provide the literature about that, but it's using it about like 2 to 3 milligrams a day, which is, about like 1/15th of the normal dose. And we don't even fully understand how it works, but there's a growing body of evidence that it does work. And I've had several successes in my own practice with it being very helpful for chronic pain. Low dose naltrexone, very low dose.
Hi, everyone. This is Rachel Bresnahan with the Michigan Opioid Collaborative. The CME code is up on the screen if you need those. And this webinar will be recorded and uploaded to our website, michiganopioidcollaborative.org. If you have any questions, just please feel free to ask me.
Thank you all for your attention. We sign off.